Okay, what is good about the lymphocytes B making the antibodies is that antibodies are going to stay circulating in our blood for, I shouldn't say for a long time. We don't know COVID for how long we're going to be immunized. According to the latest things that I read, it looks like this is going to be like the flu shot. We're going to have to get one booster every year. We don't know how long it would last, but some of our childhood diseases, our antibodies can stay circulating for up to 20 years. So that's impressive. All right, then we have monocytes. Monocytes are not very abundant, only 2 to 8%. And then the monocytes are the ones that can go outside the blood vessel and become macrophages so that they can eat big things. Monocytes are also increased if somebody has mononucleosis, right? Usually very tired and all that. Eosinophils, we have very little, 1 to 4%. These ones are very abundant if somebody has had an allergic reaction. So that's an indication that somebody had an allergic reaction if we see a lot more than 4% eosinophils. Basophils are even less, it's 0 to 1. Basophils have these big granules that they can be, they can secrete histamine. So it can cause all the symptoms of an allergic reaction, histamine. All right, so we start looking at lymphocytes. This is how they look under the microscope. All the other cells around it are red blood cells. If you look at the red blood cells, like if you look right here in the center, what I'm pointing at, it looks like they have a nucleus, but they don't. So red blood cells are non-nucleated when they are mature. And what you see there as a lighter region in the center that looks like a nucleus is because of the shape that they have. They have a biconcave shape and the light kind of like shines through, and that's what we see there that looks like a nucleus, but it's not. So when you look at the lymphocytes, you can see that their nucleus is humongous. It's mostly our nucleus and the rest is the cytoplasm. And under the microscope, you cannot distinguish B from T. They all look this way, okay? Little bigger, little smaller, but this is the way they look. You cannot really distinguish which one. This is a monocyte. These are one of the largest white blood cells, and they have like a little bean-shaped or kidney-shaped nucleus, and they're a little lighter in color for their cytoplasm. This is a basophil. So you can hardly see the nucleus in the basophil. You only see all granules, and they're called basophils because the granules stain with a basic dye. So the name doesn't tell you too much about them. This is an eosinophil, and this one has this reddish orange looking granules, and the bilobed, meaning that it has 2 lobes. So the darker in here is the nucleus. And last but not least, neutrophils. These are the most abundant ones. They're fairly large in size, and their nucleus is what we call multi-lobed because it has several lobes. So you can see this one has 4. Sometimes you have ones with 3, 4, 5 lobes even. So when you do this little lab, what you're going to do is you're going to prepare a blood slide. It's called a blood smear. And you're going to look for the different numbers so that we can get a percentage. So when you do it by hand, which nobody does it anymore, but I used to do it. When you do it by hand, you look under the microscope and you have to go through the slide in a very particular pattern. And out of 100 that you see, you have to mark how many of each of these kind of white blood cells you're looking at. and that's your percentage. So you know that you have to look for 100 white blood cells and which kind each of those are. So if you count 100 and you see 4 is 40% and like that. So this is how we do it by hand. Now, you put your blood in one end and the automatic analyzer tells you at the end what you have, which is a lot easier and you can do a lot more each time. But this is how we do it when you do it by hand in a microscope. And the blood smear is, you put a drop of blood on one end and with another slide, you kind of like spread it that way. And you have to look for the different white blood cells at the end of the spread, because over here is too thick and you're gonna have different layers. So it's better to look for it right here, not all the way to the end to the left because it's too thin, not all the way to the right because it's too thick, just here. And this is how you should move your slide in order to find about 100 white blood cells. So that's how we do it by hand. So any questions on the differential blood count? So you probably had it. You get a CBC, which is the total blood count. It will give total red blood cells, total white blood cell, and the differential count of your white blood cells. That includes everything for your doctor or physician to see. Another exam that is very easy to do is called the blood hematocrit. And the hematocrit is the percentage of erythrocytes or red blood cells in relationship to whole blood. So what we do is we pack the blood, whole blood, in a little capillary tube, and then you have to seal it on one end, and then we centrifuge it. And that separates the form elements from the plasma. And the whole thing, plasma and form elements, is considered 100%. And we have a little scale that you slide and you can calculate what is the percentage of the formed elements. Now, of course, in our blood, most of our formed elements are red blood cells. In the same hematocrit, you may see in the limit between the red and the plasma, you may see a tiny, tiny little line that is whitish in color. Those are your white blood cells, which are a lot less in numbers than red blood cells. So when you look at a hematocrit, if you see a lot of that little layer of white, then that's an indication that something is not right. Immediately, you think it's an infection. It's an increasing white blood cells, maybe an infection. But of course, you need to do more studies. And that's where the blood smear, the differential count, comes in handy, because you can tell which of the white blood cells is increased. So for males, a normal hematocrit is 42 to 52%, and for females is 37 to 47. So sometimes the doctor may think, oh, you're anemic. What is the best, fastest way to determine if you're anemic? You do a blood hematocrit. If you see that your hematocrit is 28, that's very low. That means approximately 2.8 million red blood cells per cubic centimeter. So average for male and female is about 4 to 5 million, right? So when you look at the percentage in the hematocrit, you can relate it to the amount of red blood cells. So a 37% will be 3.7 million. A 42% will be about 4.2 million, right? So if you see a hematocrit of 20 or 25, you know that this person is anemic. The other thing could be the other way. If the hematocrit is over the normal values. So the one thing that is the most common is somebody's doing blood doping. So they check for this in athletes as well, because obviously if you add anything to your blood that's going to create more red blood cells, you have higher oxygen carrying capacity. And that is good for somebody that needs it, right? So this is what happened to Lance Armstrong, the cyclist. Remember, he got all his medals and all his awards were taken away because, yeah, he was amazing. He was doing this. He was increasing his oxygen carrying capacity. And there's several ways in doing it. You can have a blood transfusion. You can have increased hormone. Steroids will give you high blood count. So obviously it's cheating, right? You're an athlete, but you're not really doing it on your own. But when you're in high altitude, for example, that can also cause high blood count. And the reason for the high count in high altitude is that at sea level, we have a certain number that is good for keeping us with the right amount of oxygen. When you go to high altitude, the oxygen carrying capacity decreases. So your bone marrow needs to make more red blood cells to account for the decrease in the oxygen carrying capacity. So the oxygen carrying capacity is given by hemoglobin. Hemoglobin is a large protein, which gives the pigment red to the red blood cells. And that's the molecule that carries oxygen. But when we got to higher altitude, the hemoglobin cannot carry the same amount of oxygen molecules that it can when we are at sea level. But your body compensates. This is a word that you're going to hear several times, especially cardiovascular. The body compensates by making more. So I don't know if you've ever been to a high altitude place, but if you go, the first day you may be a little dizzy, you may get a headache, and that's because you don't get enough oxygen to your brain, okay? Now, if everything is normal, your bone marrow detects this, it's actually your kidneys, and the kidney sends this hormone. Somebody remembers the name of the hormone that the kidneys secrete when we have low red blood cell?
Erythropoietin.
Yes, erythropoietin. So that one goes straight to the bone marrow and it tells the bone marrow to make more red blood cells. Now, some people are really good at this. They respond really fast. But it takes about a day or two to get used to the high altitude. But some people are really bad at this. I remember when we were younger, we went skiing at Deer Valley, Utah, and it's fairly high. And one of our friends, he was an athlete, he was a tennis pro. He got there and he spent the whole vacation laying on the couch because he could not lift his head. So that tells you that he was not really compensating and making more red blood cells. He was constantly with headache, nauseous. He could not do anything. So that happens too. Yes, Julie.
Okay, so instead of waiting for your body or for your bone marrow to make more red blood cells, couldn't you compensate by just taking in like more inhales, like just breathing more to provide your body?
That happens anyway, because that's another compensatory mechanism of your respiratory system is detecting that not enough oxygen is getting there. But the red blood cell is the one carrying it to the brain. And that's what it's really hard. So you need to make more. And all of us do. It's rare what happened to our friend. All of us do. And it's just 24, 48 hours the most. When I took students to Galapagos, first you had to fly to Quito. Quito is the capital of Ecuador. And Quito is about 10,000 feet. So most students got a headache, but they were okay. One of the students got really sick, nauseous, throwing up, couldn't pick up their head. So we had to call the doctor and they give you some medication for the nausea, the headache. And she had to stay about 3 days in her room because she couldn't function. So it all depends on your body. You know, we're all so unique. And this is such a little thing that we have to do that is so normal for everybody. But some people have this issue and And it's really is debilitating because you have nausea all the time and you can't really see well and you're dizzy. It's not good. But the other way around is for the athletes, right? To do doping. So in this virtual simulation, you're gonna take the hematocrit of some athletes and you're gonna determine which one is the one that is doping. So he gets all his medals taken away. So this is the centrifuge for hematocrit. So what you see here are all these little capillary tubes, okay? And this is very easy and fast. You just need to prick your finger. You just put it together right there and the blood just goes up into the capillary tube. You have to remember to seal it, right? So we put a little, what do you call it? It's like Play-Doh, a tiny little thing to seal it. And then this is the centrifuge for these little capillary tubes, right? It has also a top that is screwed here. And so they're firmly protected, and you centrifuge it. And then we're gonna have the separation between the form elements and the plasma. Well, I used to do this for a living when I was in Argentina. I was very young. And one day I was in charge of doing hematocrit for a lot of patients and I forgot to seal them. So guess what? When I opened my centrifuge, they were all empty and the blood was all over. So that was not fun. I had to call every single patient again and clean the centrifuge and do this again. So if you ever have to do one of those, don't forget to seal the little capillary. The centrifuge, emptied all the tubes. But it only happens once, right? Once you do it once, then you're like, okay. So then here's your little tool that we have. So it's like that, and you have the graduation goes from 0 to 100%. And you can see here a little line that says stop a plasma. And then you can see the bottom will be the seal, putty, that's the word I was looking for. It's not Play-Doh, but putty, it's the same. And then you measure the amount of the form elements. And so when you measure out of 100, you have to make sure that you put the plasma right here. Some people have less blood, so you have to slide the little capillary tube down, or some people have more, so you slide it up. But as long as you have the top of the plasma at the 100 mark, the bottom of the 0, and then you read whatever the form elements go. In this particular case, it's 2 lines below 50, so it's 48%. So this is a fairly normal hematocrit for somebody, right? Okay, the other thing that you do, because this also gives you an idea of the oxygen carrying capacity, is the hemoglobin content. So hemoglobin, remember, is the big protein that can carry oxygen. So it's bonded to hemoglobin, the oxygen. So the reason that red blood cells don't have any nucleus is so that they can carry the maximum number of hemoglobin molecules. Because if you know, all the cells, their nuclei are very big. So when the red blood cell is mature, gets rid of the nucleus, and that's where it can carry the maximum amount of hemoglobin molecules. So in order to measure hemoglobin content, which is measuring grams % or grams per 100, we have to lyse the red blood cell, right? So we have to break it apart and take the hemoglobin out. So that's what you do when you want to determine hemoglobin content. We have to take the hemoglobin out of the red blood cells, and then you find the amount of hemoglobin. So these are the normal values for 14 to 18 for males, 12 to 16 for females, and it's a little less because it's just size. So again, when you have abnormally elevated hemoglobin content, you also think about blood doping, right? Because you are increasing your oxygen carrying capacity. You have more red blood cells, that will give you more hemoglobin. So this is two ways that you can determine blood doping, or the other way around. If your hemoglobin is too low, then you can tell this is anemia. So you can have anemia because of low red blood cell count or low hemoglobin content. So in this simulation, again, you're going to measure the hemoglobin content of the 3 athletes, and you're going to see which one is doing blood doping. Of course, we have some that they do. So what happens is that you have to lyse the red blood cells. So that's why it says here, blood must be placed in a chamber and stirred with a chemical. The chemical is just breaking the cell membranes so that we can have the hemoglobin come out into the solution. And then you put it in a hemoglobinometer, and that tells you how much hemoglobin we have. So this one was a little tricky when I tried to do it. I don't know if you have completed this one yet, but it was hard to get to see only one color, right? In the view of the hemoglobin meter. So, and then as you get closer to have just one smooth view, then you can determine how much hemoglobin is there. So grams per cent or grams per 100. So right here you have the meter reads 15, right? Because you have 14, here is 16. So this line gives you 15. It's a little close up of the counter. All right. So blood typing. Yes, Julie.
Really quickly, so when someone's blood doping, are they just increasing the amount of red blood cells, or is there something specific about those red blood cells? Like, are they enhanced? Are they a certain type?
No, it's just that having more red blood cells will have, of course, more hemoglobin.
Got it. Okay.
Yeah, they're increasing the numbers. All right. So now we go to blood typing. So blood typing is very important, especially if you think about blood transfusions, right? Blood transfusions are vital for somebody that has had a hemorrhage or some burns when you lose a lot of fluids from your body. So blood transfusions are essential. And obviously the best thing is to get your own blood type, meaning if you're blood type A, you have to get blood type A. If you're B, you get B. If you're AB, you get AB. If you're O, it's better to get O. So I'm sure you've heard that O is the universal donor, right? You've heard that, right? Or that AB is the universal recipient. Now, this is for cases of extreme emergency. So if you are in the middle of the war zone and you're bleeding, obviously you want to get any blood, because what they want to do is to keep your heart pumping. So that's why they have a lot of blood type O, to make sure that this patient or this soldier that is injured can get to the hospital. When they get to the hospital, for sure they're going to give them their own type of blood. And this is very important to understand because, for example, if you think about a surgery, and I remember when my mom was alive, she had several surgeries, and you want to get your own blood. They don't give you type O after a surgery if you lost a lot of blood. They give you your own. So that's why you have to ask for donors, right? Because they take it from the blood bank, but you want to replace it. And it has to be the same as the patient, because it's enough to have a stress of a surgery. You need to get the same type of blood. So I want you to understand that, because I know that, oh, I can get blood type O and that's it. No, it's if you're under an emergency, okay? Same with the AB as a recipient, that he can get any blood. Yeah, he can get any blood, because all we want is to keep the heart pumping. And then you get to a hospital, they give you your right blood, okay? So there's two major are called antigens that we want to type when we are typing blood. There's a lot more that we don't type, all right? These ones we type because these are the ones that give the strongest blood transfusion reactions, right? So somebody that gets the wrong type of blood will have a severe reaction. The most likely reaction is that your red blood cells are gonna lyse, right? They're gonna get destroyed. So that's serious. That somebody can die when they get the wrong type of blood, right? So what these are called, they're little glycoproteins that are attached to the cell surface of the red blood cell. They're like little flags that they're on the outside, right? So if you're blood type A, that little glycoprotein says A. If you're blood type B, that little glycoprotein flag is gonna say B. If you're blood type O, you don't have any flags. So they don't have any of these antigens. They don't have A, they don't have B. That's the reason they're called O. And if you're blood type AB, you're gonna have both. You're gonna have a little flag that says A and a little flag that says B. The other antigen that they check for is what is commonly known as the RH. Now the antigen is really called D. These antigens, they all are called by letters, right? Remember, I told you we have more than these three, A, B, and D. We have M, N, O, P, a lot in the alphabet. But those don't give you the stronger reaction, so they're not typed, okay? So having the D antigen, again, is another glycoprotein that is a little flag. If you have it, then you're gonna be considered Rh positive. If you don't have it, then you're considered negative, Rh negative. So why do we call it Rh? Because this antigen was discovered in the rhesus monkey. Rhesus monkey. So the rhesus monkey, oh, come on. Why can I write? Pen. I wanted to write rhesus. Uh-oh. Eraser is on. Okay. We'll try again. Oh, there it appeared. Rhesus monkey is a species of monkey, okay? And that's where the Rh came from. So it has nothing to do with the D antigen, but we call it that way because it was first discovered in that tiny little monkey. Now, not only that we have those little antigens, and of course, those are genetically inherited, okay? So this is the way you're wired. You come out this way, right? Not only we have those attached on our red blood cells, but at the same time, we're born with antibodies in the plasma. So when you have blood type B, your antibodies in your plasma are anti-A. So the reason is that if you have a B and an anti-B, they are going to clump, and that's not a good thing. So genetically, we have the total opposite. So you're born with the type B, your antibodies in the circulating plasma are anti-A, so they don't clump. The clumping is called agglutination, it's coming. If you're born with type A, so you have the little flag on the surface of the red blood cell, your plasma is gonna have anti-B. Again, you don't want agglutination to happen, right? Now, if you're born with type O, since you don't have A or you don't have B on the cell surface, you have both antibodies. You have anti-A and anti-B in your plasma. And if you're born with type AB, meaning you have both your little flags, there's no antibodies in your plasma. Now, for the Rh, those don't have antibodies unless you have been previously exposed to a blood with a different Rh factor. And that you'll see when we talk about pregnancy and the mom being Rh negative and the baby's Rh positive and the second baby is a problem. So that's when you have the problem. But we don't test for that because we don't have anti-D antibodies normally in your blood. So is that clear or is confusing? See, it was confusing when I first learned about this. So you're going to determine blood type. So you're going to determine if the patient is A, B, O, or AB, and also if he's Rh negative or Rh positive. So here are some of the wording that you're going to be looking at. So we mentioned that those little glycoproteins or glycolipids are antigens, the little flags, they're called antigens. The antibody are the ones that are in blood plasma. And if you have an antigen with a specific antibody, if they meet, they're going to cause what is called agglutination. And agglutination is clumping, right? So it's something that we don't want in our blood vessels, right? So that's the reason why we have to put the right blood type so that we don't create agglutination. So antibodies are called agglutinins and antigens are called agglutinogens. If you don't want to remember that, I'm fine with antigen and antibody. Just remember that antigen and antibody, when they get together, if they're the same kind, they cause agglutination, which is the clumping, okay? And then positive, I like this one, doesn't mean good. Positive means that what you're testing is present, and negative means that what you're testing is not present. So this will be for the Rh factor, right? Having the D antigen makes it positive, not having the D antigen makes it negative. And then the serum or sera in plural is the fluid, is your plasma that contains the antibodies. So this is how we do blood typing. So blood typing is looking for agglutination. It's looking for that clumping that we're talking about. So when you look at this, I'm gonna stop sharing. I wanna do my own so that you can you see the whiteboard? Okay, so usually we have what are called little plates like that. And we have 3 wells. This is usually how you do blood typing. And this well is gonna say A, this is gonna say B, and this is gonna say D. So remember that D is for Rh, right? And so when the patient comes, what you do is you just take 3 little blood drops of the patient and you put some little drops in each of the wells. And then you go and you have commercially prepared what is called anti-A, anti-B, and anti-D. This, oh, wow, that's crazy. These are commercially prepared, so you buy them, okay? So you have little bottles. So what do? You put anti-A here, you put anti-B here, and you put anti-D here. And then you mix it all together. Mix it all together. And wait a minute. And then you look, because you can see it with your naked eye. So if you have agglutination on A, clumping, and you don't see agglutination on B, and you don't see agglutination on D, what do you think you have? What is this patient now? The patient is A, Rh negative. Yeah, because I added anti-A here and the patient is A, so that means that they reacted and I see the little clumping. But here the patient is A, but I added anti-B, they don't clump, they don't agglutinate, so I don't see anything here. And the patient doesn't have the D, I added anti-D, there's nothing to react with, so I don't see agglutination. So that tells me this patient is negative. Is that clear? Because it's a little different than learning about blood typing, right? The patient is blood type A, but what kind of antibodies does this patient have in his plasma?
Anti-B.
Anti-B. Perfect. Yeah? So we do it with another example. We do, oh, now it's going to be this way. So again, I have my A, my B, and my D. And these come like that. They come labeled, okay? So I have a patient that comes and I want to know what blood type the patient has. I have no idea. So I have to put drops here, drops here, drops here. And then I'm going to add my antibodies. I put anti-A in here. I had to put anti-B in B, and I had to put anti-D in D. And I wait a little. And this is very easy. You mix it with like a toothpick and you wait, and you can see it with the naked eye. You don't even need a microscope. So now I see agglutination here, a lot of clumping. I don't see it in A, and I see it in B. So this patient is what?
B positive.
B Rh positive. Yeah. And what are the antibodies in this patient's plasma?
Anti-A.
A. Perfect. Got it? Now, what happens if I see, so if I don't see any agglutination in any of the three wells, what's that patient?
O?
Oh,
No, AB.
no, if you don't see any, it's O, Rh negative, your best friend. Right? Doesn't have A, doesn't have B, and doesn't have D. You don't see any agglutination in any of the wells. So that's why I said this is your best friend, right? You would need somebody like that if you're in the middle of horrible accident with a lot of bleeding and things like that, right? All right, so the other one, if we have this, and we have A, B, and D, and then I have my patient with blood, and now I'm going to see agglutination in all of them. Heavily agglutination in all three. So my patient is AB, because I see agglutination in both, Rh positive. And what are the antibodies in plasma for this patient? None. He's born this way because you don't want to be attacking your own red blood cells. So now, do you understand why, if you're having surgery, you can have type O? Because the type O that is coming, that blood that is coming to your body, what kind of antibodies does this person have? Has both, right? Anti-A, anti-B. And if you're A or if you're B, still they're going to be attacking your red blood cells. Imagine that's tremendous stress for a surgery. You don't want to have that other stress. So you need your own type blood. Same thing happens with this case. If the patient is AB, can receive from anybody, right? It's what we call universal recipient. But that's not true, because if this patient receives type A, what else is
Anti-B.
anti-B? And it's going to be attacking the B that he has in his red blood cell. Or if he gets the type B, it's going to be getting anti-A, right? And if he gets type O, which is the universal donor, it's going to be getting anti-A and anti-B as well. So the universal donor, universal recipient, we need to kind of like understand when we need to use those, right? It's for specific situations, massive bleeding, hemorrhage, a patient needs to be taken to the hospital. You have to keep him alive with the amount of blood so that the heart can keep pumping. The minute they get to the hospital, they get their own type. Is that clear?
So for O type and
Yes.
have emergency surgery, is it all donated blood then?
Yeah.
You have to
Yep.
have a, okay.
Yes. And donated is, and with the all the way down to the RH. Yes. My mom was blood type A, and my sister and I had A. We were the same. So when she had surgery, we will always go and donate. Yeah, they didn't put our own blood into her mom, but she was getting blood type A positive, right? So we went to the blood bank to replace whatever they were giving her. Yes, Julie.
Sorry, today I have a lot of questions. Okay, so I was just about to ask, then why wouldn't AB be the universal donor, because it doesn't have any antibodies? But if the recipient is A, they're going to have anti-B, so they can't receive AB.
Right.
Okay.
They're going to attack the AB they're receiving.
Got it. Okay.
So it's complicated. So I don't know if you remember, there was this case, I think it was UCLA. This little girl was having a heart transplant. Not only they gave her the wrong heart, it was typed and everything. They gave her the wrong type, but they also gave her the wrong blood type. How do you do that in a heart transplant surgery? It's beyond, right? Well, she died, obviously. Everything was wrong. So it is important to do blood typing, and it's so fast and so easy, and it doesn't take long. So anyway, here is where you recognize agglutination. It doesn't look like my horrible drawings, but it looks like that, just like that with the naked eye. So you see little agglutination. So you can see that here there's agglutination, and here there's no agglutination. It's very smooth. So this patient is A, right? And then the next one over, no agglutination with A, but yes with the anti-B. So this patient is B. And then this one, you clearly see agglutination in both of the wells. So the patient is AB. And the next one is how an O patient looks like. Very smooth, no antigens. So it is O. And then the anti-D is the same. Agglutination means Rh positive. No agglutination means Rh negative. So any questions on this? No? Sounds good?
I have a question.
Yes.
My friend donates plasma for babies. So is that Rh negative, O Rh negative? Or what would she have?
He donates plasma for...
She donates plasma. Well, she donates blood, and she says her plasma is for the babies.
Well, it has to be for the right baby, right?
Well, I don't know. She says her blood is unique. So she actually, when she goes to donate, like she cuts in front of the line because her blood.
Oh, she must be O negative.
Okay.
She must be O negative. But one thing that they do for babies as well is that they harvest platelets from the plasma. And sometimes babies need platelets only. So they would just strip the blood from any antibodies, and they would just harvest platelets. which is something else, right? Platelets are fragments of a very large cell that we have in the bone marrow that when they're ready, they come out in circulation, and they're tiny little fragments of that major big cell, and they are platelets, and they're involved in blood coagulation. So sometimes somebody that doesn't have the right amount of platelets, they need that specific transfusion of just platelets. And somebody with an O negative, they're very safe. If anything is left in the plasma, they're pretty much safe because they don't have any antibodies, antigens.
Okay, thank you.
All right. What else? I don't want to do this. Come on. All right. So here is basically what I did. How do we check for the antibodies? So anti-A means antibody A, and it binds to the specific A antigen, right? Anti-B, remember these are commercially prepared. It binds with B. It has to be specific. Anti-D, it binds with D antigen. So it has to be very specific. So this is what we use for typing, right? So this little picture may show up in your exam or something similar. And you have to tell me what blood type that is, right? What do you think? Here, this number 3. Here. What is this patient? Blood type. Yes, anybody? I'll take anybody.
B positive?
No agglutination on A, right? You don't see anything, it's very smooth, right? You see agglutination here, you see agglutination here. So this patient has
B positive.
Rh positive. Yeah. Got it? Oh, it told you right here. Why didn't you see that? All right. So it's we've been here an hour, so let's break for about 10 minutes, and we're gonna start with cardiovascular, which is my favorite. All right. So I'm gonna stop recording so that we don't record our break. So I was trying to download the other presentations so that we have it. But I want to go, where is it? Here. Where was my lab? Here we go. All right, can you all see that?
Yes.
Blood pressure. Okay. So the other labs that you have to do, the other little simulations is blood pressure is one. So you all know when you go to the doctor, one of the first things they do is to take your blood pressure. And I always think that they take your blood pressure right when you come in after parking your car, walking, and you get there and you're a little nervous too because you're going to the doctor and they take your blood pressure right away. And that's not the very accurate blood pressure because blood pressure could be affected by just you walking upstairs, going to the doctor's office, right? But anyway, blood pressure is a good measurement that it tells the physician the force of blood that it goes against the wall of the blood vessels. And when the blood first leaves the heart, it's the highest blood pressure, right? And as the blood goes into the smaller and smaller blood vessels, the blood pressure starts to drop. So the highest blood pressure will be at the aorta, which is the major artery that comes out of the left ventricle. And it will be the lowest, almost zero, when the blood is doing the return, the venous return, all the way back to the superior and inferior vena cava. So in between, the blood pressure is what takes blood to the tissues. And it's very important because the main function of the cardiovascular system is to, a word that I love to use, is to perfuse the tissues, right? So perfusion is exactly what the cardiovascular system is doing. Pen, let's see if I can write it. Perfusion. So the main function of the cardiovascular system is to perfuse all your tissues, every single cell in the body, right? So we need the heart to be doing its job, but we also need our blood vessels to be taking nutrients and oxygen to the tissues. And at the same time, we need our veins to pick up the waste and carbon dioxide. So blood pressure has to be so that we have enough force coming out of the heart. And by the time we get to the tissues, we still have enough force to do that diffusion at the tissue level. And also we have to have enough strength still to pick up the carbon dioxide and the waste, soluble waste, to return to the heart to be reoxygenated again. So that's why it's important to understand blood pressure and to measure it, right? So blood pressure is influenced obviously by cardiac output. And remember what cardiac output was, SV times HR. So it's stroke volume times the heart rate. It's also affected by peripheral resistance, which is the rubbing of the blood against the walls of the vessels. And the smaller the vessel, the higher the resistance, right? And it also is affected by blood volume. We mentioned that if you have high blood volume, the patient is going to have high blood pressure, which is not good, because for one, it can burst little vessels in the brain, right? It comes out of the heart and goes up to the brain and it bursts the little blood vessels, and that causes a cerebrovascular accident, right? But also the blood pressure is affected by body position. How many times you've been laying down in bed and you get up really fast and you're dizzy, right? Oh, why did you do that, right? You change your body position very fast. So the heart, it didn't have enough time to pump blood to the brain, and that's why you get a little bit dizzy. Exercise also affects your blood pressure. When we start exercising, the heart senses that you need to pump more blood to different organs, mostly skeletal muscle. So you increase your heart rate because of that. So there's many variables that can affect blood pressure. So when you take blood pressure, you get two numbers. You all know that, right? The highest number is the systolic pressure. And this is when the blood is coming out of the ventricles. That's why they call it ventricular contraction, right? And diastolic is the pressure, which is the lowest number. And this is when the blood is returning to the heart. So that's why it says there ventricular relaxation. So remember, the heart needs to be relaxed in order to accept blood coming in. And when it contracts, it's pushing with the highest force. So those are the two numbers that we measure when we measure blood pressure. So you've all seen this, right? This is the pressure cuff that the doctor or the nurse puts on your brachial artery. So it shows here your brachial artery, yeah, which is the artery on the upper arm. So they put the pressure cuff there and they start pumping, right? Until they occlude or they close your brachial artery. Now, why are we measuring in the brachial artery? Well, for one, because it's easy. It's easy to put a pressure cuff on your arm, right? The most accurate way to measure blood pressure will be to have open heart surgery and have a probe inside the aorta. That'd be the accuracy, right? Not possible to do at the doctor's office. So the next thing is your brachial artery, right? So that is easy. So from anatomy, and you don't have to know anatomy right now, but if you took anatomy, you probably remember that the blood comes out of the aorta, and then the aorta starts to branching into the smaller arteries. So there's the common carotids on each side of the neck, and that's a branch of the aorta, the aortic arch, right? And they go up so that they can supply blood to your brain. But then the aorta also branches into the subclavian, which goes right on the clavicle, right? And that subclavian then branches into the brachial, which is the one that we're talking about, which is your upper arm, right? So that's the closest to the heart. The brachial artery is the closest to the aorta, right? Because we cannot have open heart surgery and put a probe on the aorta. The closest thing will be your left brachial. So when you go to the doctor, and it has happened to me, and remember, I don't tell doctors or nurses what I do for a living. So when they tried to take my blood pressure on my right arm, I just looked at them like, all right, right arm is not closest to the aorta. Aorta branches left first. So you have to do it on my left. That's where they have to do it, right? Sometimes they do it whatever is more convenient for them, but that would not be as accurate, okay? So the left arm, left brachial, that's the most accurate. It's just because it's easy to wrap a cuff pressure around the arm. Imagine you can't wrap a cuff pressure around your clavicle. So that's why, so clavian will be closer, but it's not as easy. So this Russian physiologist, Mr. Kharkov, he figured it out that if we measure the pressure on the brachial artery, it's very close to the aorta to measure the systolic one. So the whole purpose of the pressure cuff is to create enough pressure to occlude or to close the brachial artery. So this is the very simple thing that he came out with. You put a stethoscope there and the doctor would listen for the sound. So what sound are we looking for? So two sounds, and they're called the sounds of Kharkov, right? The first sound is the systolic pressure. The second sound is really the disappearance of the first sound. I know it's weird, but that's how it is, right? So imagine when you're in the garden and you have a garden hose on, right? So you have your water running, coming out of the hose, and then all of a sudden you create a kink, yeah? So if you kink your garden hose, there's no more water coming out, right? The other end. But what happens when you let go of the kink? How does the water come out? Like fast, right? Because while you were making the kink, the water was bumping onto that occlusion, and the minute you let it go, then the water comes out running, right? So this is the same principle for blood pressure. You occlude the brachial artery, so you stop the blood there, and then slowly, listening with a stethoscope, slowly you start releasing the pressure, and the minute that you hear that blood rushing, that's your systolic blood pressure. So we're kind of like recreating the amount of force, pressure that the blood is coming out of the heart with. Is that clear? And it's a very distinctive sound. It's really like gushing, rushing sound. And then when the sound disappears, that means that the heart is relaxed and the blood is returning back to the heart. So that's the second number, that's your diastolic blood pressure. So here you have the little picture here that says systolic pressure. The artery stretches when we let go of the kink, when we let go of the pressure and a lot of blood comes out. That's your systolic. And then when the pressure is decreasing, because as the blood leaves the heart, we start decreasing, that's your diastolic, and that's when the doctor doesn't hear anything. Now you have to have a trained ear. First time that you measure blood pressure is not gonna happen. You're gonna miss it. You may miss the disappearance of the sound, right? But of course you get practice, and this is very easy. This is the most accurate way of measuring blood pressure. We have digital, which is very easy, you just read, right? But it's not the most accurate one. The one that you listen to is the most accurate one. So, oh, my favorite word, adequate blood pressure must be maintained for proper flow to tissues or tissue perfusion, right? Without enough blood, your cells are gonna die. So you don't want to have that happen, right? So you're gonna measure the blood pressure, and you're also gonna measure blood pressure with different body positions. And then you're gonna measure blood pressure after the patient exercises. So obviously, after we exercise, you're gonna have a little bit of a higher blood pressure, right? Because your heart is pumping a little faster. So that's the name of the Russian physiologist that came out with this idea on how to take blood pressure. And they're Korotov sounds. And remember, there's only one sound really. The second one is the disappearance of the first sound. So that's what you call the diastolic, okay? So you can hear it when you do the simulation if you have your headphones and you have the volume out. So blood pressure that is considered normal is about 115/70. I know we all hear 120/80. So if you want to remember that, is fine. But for some reason, we keep lowering the normal blood pressure, and we keep lowering the normal cholesterol levels. So long time ago, it used to be 200. If you had 200 or less, you were normal in cholesterol. Now it's 180, and they want to put it to 170. So, but if you remember 120/80, you're okay. When we're younger, the blood pressure is a little lower. As we get older, it goes a little higher because your blood vessels kind of like harden a little bit with age. So we have to push the blood a little harder. Now, if you have a chronically elevated blood pressure of 140/90, that's called hypertension, right? And the body, we're going to learn that it gets used to the high blood pressure, right? So the body gets used to the baroreceptors, which are the receptors for pressure. They don't detect higher blood pressure anymore. So this is what happens to chronic hypertensive patients. And if you chronically have low blood pressure, that is about 90/60, then that's called hypotension. These people are always dizzy, and some of them are anemic. It is also a problem with high or low, right? It's the Goldilocks principle. It has to be just right. That's it for your blood pressure. So here is a little picture of what you're going to be measuring. No sounds when we are occluding the artery. Occlusion means you close up the artery, like you see here on the right, yeah. And then you start opening and you start hearing the blood rushing. And once the artery is all open, because all the blood rushed through, there's no more sound. So that's what you're going to be looking for. So the next little simulation is the electrocardiogram. And when we were face-to-face in our labs, I used to connect the student to the electrocardiogram machine, and then I will make the student go run up and down the stairs, and we'll come and record the electrocardiogram again. It was fun. I don't know if for the student that was doing it was fun, but for the rest of us that we could see it. So what I'll be measuring with electrocardiogram or ECG, sometimes you're going to hear it as EKG, right? The C is for cardio. And again, it was a German physicist that came up with this idea. So cardiac in German is with a K. So that's the reason why we call it ECG or EKG, same thing. So what are we measuring with an ECG? The electrocardiogram only measures electrical activity of the heart. So the heart is so amazing because it can initiate its own spontaneous depolarizations. Now we have to remember depolarizations are repolarizations again. This is from nervous system, but same thing happens with the cardiac muscle. So remember, with skeletal muscle, what do we need for skeletal muscle to contract? If we don't have that to start with, we can't contract the muscle. What do we need?
Calcium.
Yeah, but we need calcium, we need ATP, but at the beginning of everything, what do we need?
An action potential?
Action potential. And where is the action potential coming from?
Motor neuron.
Yay! See, if we don't have a motor neuron, everything goes poof, right? Your skeletal muscles are mush if we don't have that motor neuron. So because it's a voluntary effector, right? The skeletal muscle needs that connection with the motor neuron because the motor neuron is the one that is going to send that depolarization, right, to the skeletal muscle cell, which in turn is going to allow for calcium to come out, and then we can do the sliding and we're all happy, right? So with skeletal muscle, we know that if something happens to our spinal cord, the muscles below that are not even going to move because those neurons are not going to be sending that depolarization wave or that action potential. We get that, right? Now, cardiac muscle is involuntary. We learned that at the beginning. It's an involuntary effector. Now, the cardiac muscle doesn't need any motor neuron to tell him when to depolarize, when to run an action potential. It just does it. It's so amazing that on the right atrium, it has a group of little cells, cardiac cells, that on their own, they initiate spontaneous depolarizations. Isn't that mind-blowing that we can have that organ that is so amazing? On its own, every so often, initiates depolarizations. How often, you may ask? 70 times per minute. That's your heart rate. That sets your heart rate, right? So we are wired that way. We have this little group of cells that they are in what is called the sinoatrial node, SA node, that every so often, 70 times per minute, they will initiate spontaneous depolarizations. And from there, the action potential starts to spread all the way to the heart, all the way to the ventricles so that we can contract as a unit, right? So you know that skeletal muscle doesn't have to contract as a unit. You don't have to contract your leg muscles to contract your arm muscles and so on, right? They're very isolated. But the heart is a unit and it has to contract as one, right? So the electrical system of the heart, or the conduction system is also called, are this electrical activity that we have in the heart that tells us how well the heart is depolarizing and repolarizing, because a depolarization is equal to a contraction in the heart. And what do we say the contraction is called? Systole, right? So we can put all of that together. Depolarization is the same as a contraction, is the same as systole. When the heart repolarizes, goes back to the resting membrane potential, then is when the heart is relaxing. And we call that diastole, right? Now, because these tiny little cells in that SA node are the ones that initiates the spontaneous depolarizations, that area is called the pacemaker of the heart because it sets the pace, right? It sets the beats per minute. So sometimes people need a pacemaker. And that's because they may be having issues with that SA node, with those little cells there. those individuals are the ones that will skip a beat because the SA node is not firing, depolarizing every time. And so they need a little reminder, a pacemaker, which is installed around that area. It's a little electrical stimulation that goes under the skin, no major open heart surgery here. And when the heart forgets to beat or to depolarize, the electrical stimulator will send that signal, and the individual, the patient, doesn't even know that that's happening, right? So when one of our cadavers, I think we don't have that one anymore, it had a pacemaker. When we were doing the dissection of the pectoral muscles, you know that you have to go through layers. If you take anatomy, you might see that. And we started dissecting, and all of a sudden I clunk on something. It's like, whoa, this is hard. And it was an old one because our cadaver was somebody that had died at 90 something. And the little pacemaker is around like this, and it has a long, long little wire that went all the way to the heart. So amazing that we saw that. So let me show you this first before the others, because this is what we call the electrical system of the heart, or the conduction system. So the heart is made out of 4 chambers, 2 superior, 2 inferior. The 2 superior are called the atria for plural. Singular is atrium. So we have a right atrium and a left atrium. And then we have 2 ventricles, a right ventricle and a left ventricle. Now, when everything is normal, the atria do not connect with each other. The ventricles do not connect with each other. They're separated by this wall, right? And you see here, it's a little skinnier, is the interatrial septum, which means separation. And then this one, a little thicker, is the interventricular septum, okay? So other things that we see here, obviously, first thing that jumps at you is that half of the heart is blue and half is red, right? So in anatomy, they always represent the arterial blood in red and the venous blood in blue. So it's not really blue, it's just that it's a little darker red. So to identify it in books, we give it the blue color to mean or to distinguish it, and to think that this blood has less oxygen than the arterial blood. So the electrical system of the heart starts here in this upper right atrium, and you see that little yellow oval. Those are those cells that spontaneously start depolarizations 70 times per minute. So that action potential, that wave of depolarization, starts to travel through the heart, and you can see those little pathways here, that you can see that from the SA node, it goes all the way to the left atrium, and it also comes down right about in the center where we have more cells that are called the AV node that continue with that depolarization. And then the depolarization travels through the interventricular septum in what is called the bundle branches, or AV bundle of His is another name. And then at the end, they branch and they go up. Like you can see, it goes up the right ventricle and up the left ventricle. And those are called Purkinje fibers, Purkinje fibers. So when I ask you what is the electrical system of the heart, or what is the conduction system of the heart, you have to say it starts in the SA node, goes to the AV node, it comes down through the AV bundle, and then it ends in the Purkinje fibers. And so that would be like the pathway of depolarizations, right? So the electrocardiogram is testing for this electrical activity. We don't know if the person has a I don't know, some malformation of the heart. The electrocardiogram doesn't give you that information. The electrocardiogram gives you electrical activity. So where is that electrical activity coming from? Well, these very specialized cells are like specialized neurons. So they can depolarize and repolarize. And this is electrical activity that can be measured with surface electrodes. So the electrical activity is measured through the skin with electrodes, right? It is an electrical activity because it's just a rushing of positive charges and then stopping that rush of positive charges and coming back to resting membrane potential. So that's what the electrocardiogram is measuring, right? So we can interpret that information and we can realize, okay, is the heart relaxed enough time to allow for blood to come in? Is the heart contracting enough time to allow for the blood to be pushed out? So those are the things that doctors look for in an electrocardiogram, right? For example, if a patient is having a myocardial infarction, they can see that too, because the electrical activity is going to be affected in the area where the heart is, cells are not normal. A myocardial infarction is cells that are being destroyed, cells that are dying, right? And those cells are not going to be able to be sending that electrical activity or the depolarization wave the same way as a normal cell. So those are the things that we can tell in an electrocardiogram. So I'm going to show you what we measure in an electrocardiogram. This is what we measure. We measure a cardiac cycle. So what is a cardiac cycle? A contraction and a relaxation together makes one cardiac cycle, okay? So the first wave in an electrocardiogram that we measure is this one, or we see, is what we call the P wave, okay? So as you notice, this P wave is not that high. It's just a fairly small amplitude. So amplitude is the height of the wave, okay? So this one, the P wave represents the depolarization of the atria. So remember what we said, depolarization is equal to contraction. You see here at the bottom, atria contract. So that's what's happening during the P wave. So the blood came into both atria, and then it has to contract to send the blood to the ventricles. In that contraction is what we measure that depolarization in the P wave. Immediately after the P wave, what does it come? The blood has gone to the ventricles, and now we have to contract the ventricles both at the same time. And that's what the QRS complex is showing. Now, if you notice, this is a big wave, right? It has a high amplitude. The wave is high because the ventricles are very powerful, right? If you think about the atria pushing blood from the top down, they don't have to push that hard. Gravity helps, right? So that's why you have a little P wave, right? It's not a humongous one. But when the ventricles contract, when they're depolarizing, they create this QRS wave, which is very powerful. Now, when the ventricles are contracting, guess what the atria are doing?
Relaxing.
Relaxing. So the atria needs to be repolarizing. And guess when they do that? They do it right under the QRS wave. So we don't see that repolarization. Isn't that funny? You can't see it because the depolarization of the ventricles is so strong that it masks the repolarization of the atria. Now, the next wave that you see here is the T wave. T wave is the repolarization of the ventricles. If you have a depolarization, you always need a repolarization, right? The cells need to go back to resting membrane potential. So depolarization of the atria in the P, QRS is the depolarization of the ventricles. At this time, at the same time, this is where the atria are repolarizing. And then immediately after the ventricles depolarize, they need to repolarize, and that's your T wave. And that's your cardiac cycle. Atria contracts, atria relax. Ventricles contract, ventricles relax. And it's one after the other, right? Because it's a wave. It's that electrical activity that travels as a wave through the whole heart. Got it? Okay. The other things that the doctors look for in an electrocardiogram is intervals. So intervals is the time for a wave to occur. So you see here, you're measuring the PR interval, and this is when the wave is occurring, right? Now a segment, right up here, is the distance of a straight line between two waves. So that's a segment. So what is the segment TP telling me? How much time I have till the next cardiac cycle? Because one cardiac cycle is PQRST. That's a cardiac cycle. The next one, same one, PQRST, okay? Now the segments and the intervals are important for physicians to know because the heart needs to contract a specific amount of time. The heart needs to be relaxed a specific amount of time. So that's why they need to know those little intervals and segments for each of the waves. Because if the ventricles, for example, they're not relaxed enough time, not enough blood is going to enter the heart, right? If the ventricles are relaxed, but they're not relaxed enough time, they're going to contract immediately and they don't allow enough blood to get in. So that the next cycle, that heart is not going to push enough blood out. So that's why it's important to understand the electrocardiogram. So look at all these little time components that you have for the electrocardiogram. And you don't need to know this one because you can always go to a chart and look for them. But you have that duration in seconds, right? Because that tells you, okay, are the atria relaxing the right amount of time? Are they contracting the right amount of time? Are we waiting enough for the ventricles to be ready to be filled with blood? Are they contracting really fast? So when you get an electrocardiogram, not only you have the recording of the little waves, but you also get information on the intervals and on the segments for each of the waves and each of the straight lines, because that gives you, the cardiologist, a good idea on how well the heart is electrically working. Any questions on this? No? So from the electrocardiogram, you can also, from the tracing, you can also determine heart rate. And the heart rate is when you measure from 1 R to the next R. And then you divide that by 60, and that's your heart rate in a minute. So if you look at the R's are the most prominent points, right? Peaks of the electrocardiogram. So from 1 R to the R, you can measure a beat per minute. So when you do a resting patient, you see the R's, how spread apart they are. Now, if the patient is exercising, you're going to notice that the R's get a lot closer. And that means increased heart rate. right? So if a patient is having fibrillations, for example, which is irregular ventricular contractions, you're going to see that these R's are totally random. They're not going to have a nice pattern, either when the patient relaxes or when the patient is exercising, that they get a little closer. You're going to get a lot of peaks at very different times, and that's a no bueno thing. Fibrillation is bad. Ventricular fibrillation can lead to a heart attack. So of course, somebody gets into the ER with chest pains, first thing they do is they do an EKG, right? The other thing that you're going to measure is pulse rate. So pulse rate is very similar to blood pressure, is how fast the blood gets to the extremities, which is where we measure the pulse rate, right? Have you noticed in medical shows or something like that, that they take their wrist and they kind of like count, right? So you can take pulse rate in areas where the arteries are very superficial to the skin, and the blood travels in this pulsating manner, pulse rate, because of the heart rate, right? So in a way, when you measure pulse rate, you really are measuring heart rate, but in an easy way, right? The doctor will take it from the radial artery, which is the one that goes with your thumb, right, on the wrist, and that little artery is so superficial that you can actually palpate and you can hear it or feel it, the rate, right? And of course, also it's affected by emotions or by exercise or the position of the body. So what you're going to do again here, you're going to measure patients, and you're going to see where you can measure the pulse rate, locations in the body. And you're going to compare with different arteries that are smaller, or arteries that are closer to the heart. They're going to have higher pulse rate. There are arteries that are away from the heart, right? Because remember what happens. The highest blood pressure is at the aorta. And as we get down and we start distributing the blood to the body, it drops, right? And it drops until we turn all the blood back into the heart so that we can reoxygenate it in the lungs again. So you're going to also compare the pulse rate in different positions when the patient is sitting, laying down, or standing. And of course, what happens after exercise. And you know what happens, right? Same with blood pressure. When you exercise, your pulse rate increases. So when the blood is coming out of the heart, you have your systole, and the blood is strong, is high coming out. And when you're relaxing, your diastole, the blood pressure is less. Or pulse rate, remember, it's the same thing. So these are the different areas that you can measure the pulse rate. So one common one is the carotid, right? When you're exercising and then you're cooling down, you kind of like put your finger here on the side of the neck, and that's your carotid. That's a very good measurement of your pulse rate, right? Because it's right coming out of the aorta, up the common carotid. So, and they are superficial. So you can put your finger there and you can palpate and feel the pulse rate. The other one, the brachial artery, the one right in your, is called the antecubital, which is in the front of the elbow, the little indentation there. Also on top of your foot, that's the dorsalis pedis artery. The femoral artery comes from the common iliac and comes down onto the femur. So where is the highest pressure is in the groin area. That's where the branch of the femoral starts. You also have the back of the knee, which we call the popliteal region. And I told you about the radial on the wrist. And sometimes when the patient is laying down, they will take it on the posterior tibial, which is the one in the ankle, right? Are just the lab simulations that has to do with chapter 13 and chapter 14. So any questions on the lab simulations? Or anything that we've done so far? No? We're good? All right. What time is it? 3. Oh boy. We have only 1 more hour. So let me just close my little lab. And I just want to go over a few things of chapter 13, but mostly chapter 14 for the last hour that I have you here. Anybody needs a break? No? Well, you know you can take a break anytime, but if I don't take it, then you miss what I'm saying. All right. So I guess with chapter 13, we're pretty good with, oh, stop. I'm gonna have to leave it here because this is my narrated PowerPoint. So we are pretty good with the different elements, form elements of the blood. And I mentioned platelets. Remember, those are the tiny little ones that are important for blood coagulation. We saw the different types of white blood cells. So this is an important little slide, which is how we make those red blood cells that I was talking about when the bone marrow is stimulated, for example, at high altitude or low levels of oxygen carrying capacity. So the bone marrow is stimulated. Yeah.
Sorry, we're not seeing the slide.
Yeah, of course. I just realized that. There you are. So it comes from this very large stem cell, right? So all of these different cells that I'm not going to ask you all the names, all the way up to here, all of these cells are in the bone marrow, okay? And then when they're ready, they become the erythrocytes, which are the ones that are dumped into circulation. So for example, if a baby is premature, right, is born before the time, we're going to see a lot more reticulocytes in the blood of that baby because that baby wasn't ready to come out, right? So the bone marrow is going to dump some immature red blood cells. Every single newborn will have some reticulocytes. That's totally normal. But if the baby is really premature, it's going to have more because this baby is out on his own now and the bone marrow was not ready and it's going to dump a lot of these reticulocytes. So if you notice, the reticulocyte has a lot of little fibers. It's not a nucleus, but it's the remnants of the nucleus. So a reticulocyte is not going to carry the same amount of oxygen than a full mature red blood cell. So that's a problem, right? All right. What other thing? Here we have blood typing, which we went through. So this is important because this is what you need to know for the exam. And when I say exam, everybody will pay attention. I'll say exam, 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 exam. When is our next exam? I don't even know. Sure you do. Because it has to be
The 27th.
Whoa, okay. All right, so remember I told you platelets are involved in blood coagulation. So when we have bleeding or some damage to the endothelium, now the endothelium is the lining of the blood vessels, right? So when we bleed, think about just cutting yourself on the outside, right? You bleed because tiny little vessels have been damaged. So the blood comes out of the blood vessel. Normally, you don't want that, right? But when we have that damaged endothelium, there's little things that happen, like the endothelium will send little fibers toward the inside where the blood is, and it's gonna call these platelets to the region, because platelets are chemically attracted to that little damaged collagen fibers and things like that, right? So whenever there's that little damage, and you see here at the bottom, you have a bunch of these blue dots. These are the chemotaxins, they're called. So they're agents that are attracting the platelets to the area. So when you look at this picture on top, each of these globe-like oval things, these are endothelial cells. On the picture on top, they're all there. So the platelets are just traveling and they don't care, right? They don't go anywhere. But if you look at this picture here on B, this cell here is destroyed. This is damaged, right? So that's when the tissue starts to send chemicals to attract the platelets. And that's when the platelets all come in and they're trying to stop the bleeding because the cell is not there. And that's how blood comes out of the blood vessel. So when the platelets are attracted and they all get together in a clump, we call that a platelet plug. That will stop the bleeding, that's for sure. But the coagulation is not all done until we create these green little fibers that you see here that are called fibrin. When we have platelets and fibrin, then we have a blood clot. And that blood clot is going to stay there until the endothelium regenerates and it closes the gap, right? So this picture here is really when you look at a blood vessel from the inside, right? We don't know when this is happening inside our body. But if you think about what happens when you break skin and it's bleeding, you get a blood clot, right? The little crust that you create in the scar is the blood clot. It's your platelets and the fibrin, the protein that kind of like intertwines with the platelets to create the blood clot. And why do we want the blood clot there? The scab, right? Because underneath you're waiting for that epithelium to grow, to regenerate and to heal. And if you don't touch it, right? Because we know that we like to pick those. If you don't touch it, then it just falls off when the epithelium is all healed, right? But what happens if you pick your scab before it's ready? You get bleeding again because your epithelium is not healed, right? So the way that it happens on the outside, the same happens on the inside, okay? For whatever reason, your endothelium breaks and you create this little blood clot. You have to stop the bleeding, right? Because blood vessels need to be within the heart. I mean, no blood vessel. Blood needs to be within the heart and within the blood vessels. We don't want it out and around, right? They can't come out. The blood cannot come out. So this part is the one that I want you to know for the exam. So we have two different clotting pathways. So the clotting factors, they're just proteins that they stay inactive when there's no bleeding, right? So if there's no bleeding, these clotting factors are circulating in your blood vessels and nothing happens. If there's bleeding, we start with a platelet plug, and then these proteins that are the coagulation factors, they start to get activated. And the way that they get activated is in a cascade fashion. One activates the next one, and that next one activates the next one, and the next one, and the next one. So this is feedback, positive feedback mechanism. Remember, I told you there's two examples of positive feedback mechanism in the human body: oxytocin and coagulation, right? Because we are exacerbating the response all the way until we create a blood clot. That's the good thing about this positive feedback loop, right? Now, there's two different pathways, and we all get to the same thing. Look what we get here. The green fibrin polymer, those little green fibers that we had in the blood clot, right? So both of these pathways get to the same point. We have to create fibrin. It's a protein, right? Now, the way that we start the coagulation is different. If it starts on the outside, like I told you, on your skin, that's why it's called extrinsic pathway. Or if it starts from the inside, like the example on the picture, like there's damaged endothelium that you don't even know, right? So it starts a little different. One thing is from the outside, that's why it's called extrinsic. And one is from the inside, that is why it's called intrinsic. But look what they both have. They have a common pathway, right? So both will take you to this common pathway. And for the exam, you need to know the common pathway. You don't need to know every single of the factors on each. You need to know how they start, okay? The extrinsic starts with the tissue activator tissue factor. What is that? Damaging skin. When you cut your skin, when you poke your skin, that the tissue is the activation for the clotting. In the intrinsic, look what it says, collagen, glass, and others. So collagen is the picture that we saw before, which are the endothelium breaking the cells, and then the collagen fibers from underneath, they are exposed. And those collagen fibers are attracting the platelets. But why would you say glass? We don't have glass in our body. Hopefully we don't. Because when you put blood in a test tube that is glass, the glass is an activator for the coagulation reaction to happen. If you don't put any anticoagulant in a test tube and you put blood and you let it sit, it will form a clot. The glass itself, the surface of the glass, is an activator. Now, all those happen, and we have to get to factor 10 to be activated. That you need to know because it's the common pathway, right? So factor 10 then activates prothrombin that becomes thrombin. And this is the cascade that I was talking about. The thrombin then activates fibrinogen, which is inactive, to form fibrin. And that's it. You have your coagulation. Now, you've heard that there are some coagulation diseases, right? One of them is hemophilia, where the patient is born without factor 8 is the most common one. Genetically, they don't make it. These coagulation factors are proteins. And you know that we get the message for our proteins in our DNA. So if you have a mutation in your DNA, you inherited that, and the patient needs to get factor 8 from the outside. So this is how a lot of children contracted HIV when in the 80s, when HIV first started. Remember that it was really sad because it was related to gay individuals, right? Having an unsafe sex. And then they started seeing a lot of children getting HIV. And so people didn't even know what happened. How is it possible that children are going to get this sexually transmitted disease, right? So they realized that the children that were getting HIV were hemophiliacs, and they were getting blood transfusions with factor 8 every so often. And at that time, they weren't testing for HIV in blood banking. So thank God they realized that, right? Because they don't make factor 8. They have to get it from the outside. So they have to have frequent transfusions of factor 8 so that they can lead a normal life, right? Because without factor 8, look, they can never get to factor 10. they can never form a blood clot. Yeah, so that's serious. And this is a beautiful picture of a blood clot. You have the red blood cells, which is what it gives color to your scab on the skin. And then all these fibers, which are the ones holding everything together while the tissue heals underneath. And same happens if we're talking inside, right? Okay, this is my favorite one. With this picture, you should learn everything in this picture. So remember we mentioned before when we did our little lab simulations that half of the heart is in blue and half of the heart is in red, right? So what happens is that the respiratory system works very closely to the cardiovascular system, because when we pick up carbon dioxide and waste from our tissues, we have to return that venous blood to the heart so that the heart can pump it to the lungs. The lungs then do their part, because at that moment that we're pumping that deoxygenated blood to the lungs, we're taking a breath in. And that's where oxygen gets there. And that's how we reoxygenate the blood. And the blood comes back and we start all over again. So obviously, if you notice, this picture is a closed circuit, right? The blood never leaves the vessels or the heart. And what you see here up here and what you see up here, this is what we call the tissue bed. So it's your tissues, right? And we have tissues everywhere, but they're indicating here up, right? Think about head, neck and shoulders, and then down will be anything below the heart, all the tissue cells that we have to nurture with food and oxygen, right? So because it's a cycle, we can start anywhere. So anybody can start anywhere to explain what is the circulation of the blood through the heart, tissues, and lungs. So I always like to start my way. I like to start always on the right atrium, just because I always like it that way. Some people start on the aorta, but I like the right atrium, because the right atrium, if you notice in blue, you have the superior vena cava coming from tissues that are above the heart, right? And then we have the inferior vena cava that is collecting from tissues that are below the heart. And both of them drain in the right atrium. So this blood is deoxygenated, right? It has less oxygen because we're picking up carbon dioxide in the tissues, right? If you notice here, we have your carbon dioxide. Oh, I can't do it because I'm not in the show, but look at here, carbon dioxide, we're picking up here, and look at the little arrow, it's going from the cell into the blood vessel, right? And then here in these tissues, again, you're picking up carbon dioxide from the cells into the blood vessel, right? So where is that carbon dioxide coming from that the cells are accumulating?
The result of cellular respiration.
Yay, Ricky. Cellular respiration, main waste product of cellular respiration, right? And we know cells are doing cellular respiration because they need ATP to do all the different things that we've learned in Bio 100 or 107 that cells need to do. Make proteins, divide, heal, right? There's also some other soluble waste. And when I say soluble waste, it's waste that is dissolved in the fluids in cells, right? So we also collect that. The soluble waste is going to be excreted in our kidneys, okay? The carbon dioxide, which is a gas, is going to be exhaled out, yeah? And we only have one more waste that we have to wait until digestive system. Solid waste is excreted in the poop. So that's how we can keep everything clean and healthy, right? So again, we start at the right atrium. We are collecting all this carbon dioxide that the cell has been building and all that soluble waste. So the right atrium collects that and then the blood goes into the left ventricle. Because by gravity, we have some valves that open, but the gravity, right? So when the blood goes into the left ventricle, then look where it goes. It goes up into what is called the pulmonary trunk, and it goes to one lung and to the other lung. So these two that are sending that deoxygenated blood to the lungs are sending all that blood to be charged again with oxygen. Now these two that are branching from the pulmonary trunk, they're called, now brace yourselves, they're called pulmonary arteries. Wait, didn't we say the arteries were red and veins were blue? Yeah, but this is the exception to the rule. The definition of an artery is a vessel that takes blood away from the heart, regardless of what it has inside, oxygen or deoxygenated blood. Yeah? So that's the reason why these two that are blue, so you know it's deoxygenated blood, is taking the blood to the lungs, so it's leaving the heart. That's why they're called right and left pulmonary arteries. Now here in the lungs, in both of our lungs, you can see what we're doing. You see carbon dioxide coming out and you see oxygen coming in. Now this carbon dioxide, when we learn about respiratory, ultimately is gonna go and do the opposite route and we're gonna exhale it out. The oxygen that we just breathe in is gonna go into oxygenated blood and now becomes the red ones, yeah? And they're red because they have oxygen, but guess how are they called? Veins. That's the other exception. The definition of a vein is any vessel that returns blood to the heart. But they're red because they have oxygen, right? So the pulmonary veins, which you see two from each lung, so we have 4 total, they drain all this oxygenated blood in the left atrium. And this blood in the left atrium goes into the left ventricle and comes out in the major artery of our body, which is the aorta. And then the aorta starts to branch, and you can see how it branches up and it brings all that oxygen that the cells are needing. And the aorta branches down and it brings all that oxygen the cells are needing. Isn't that a nice little cycle? Now, we only have 5 liters of blood total in our blood system, yeah? So we have to learn about our different vessels and how they can change the radius or the diameter with vasoconstriction or vasodilation, right? So obviously 5 liters is not enough for every single cell to get everything. Ooh, no, not now, I don't need to restart. Okay, so in my head, when I first learned about this cardiovascular figure, and I think that you should too, because it's the easiest way. When the superior and inferior vena cava are getting the blood into the right atrium, at the same time, the pulmonary veins are bringing blood to the left atrium. So it means that at the same time, both atria are getting blood from different places, but they're getting it at the same time. Now, these two from the atria come down to the ventricles, and when the ventricles contract, they're pushing blood at the same time. They're going to different directions, but they're doing it at the same time. So the left is sending it to the aorta to send to the rest of the body. The right ventricle is sending the blood to the lungs to be reoxygenated. So this is a process that is going on at the same time. When I was learning this as a student, I had a hard time figuring that out. because it's a cycle and you can start anywhere. I thought that the blood that I'm collecting in the right atrium had to do the whole thing before getting to the aorta, and that's not the case, right? We're getting blood at the same time, and we're pushing blood at the same time, but to different places. Is that clear? So the right ventricle pushes blood to the lungs. The left ventricle pushes blood to the aorta, to the rest of the body. So imagine how related the lungs are and our respiratory system is with the cardiovascular system. If your lungs are not working the right way, we're never going to get enough oxygen to send to the rest of the body, right? So they are totally related. They are close to each other, right? On each side in the chest cavity. So they're completely related. And that's why when we first started this class, I said, major systems that you have to relate and learn how to interconnect: cardiovascular, respiratory, urinary. Now you start seeing why, right? Because urinary is gonna filter the blood that has those soluble waste that we have to get rid of, which is mostly nitrogen, which is what your cells are doing when they're making proteins or breaking down proteins. Yes, Julie.
Forgive me if you already said this, but I'm just curious, like if we had a tracker and we started in the right atrium, how long would it take that to return to the right atrium?
That little drop of blood, a cardiac cycle.
Yeah.
A cardiac cycle. That's why it's gonna take that long.
But how long is that?
70 times per minute. So it's 70 divided by 60.
Not long at all.
No, super
Oh,
fast.
wow. Through your whole body?
Yes,
Wow.
yes, it's so fast.
Okay, thank you.
Remember the intervals and the segments, we were measuring them in seconds. So imagine, right? What I was gonna say. I didn't say that, like the question that you asked, I hadn't said that, but that's a very interesting question. A question that I usually used to ask when I taught anatomy is: trace a drop of blood from the tip of your big toe to the left ventricle. So they had to name every single vein and artery all the way until they got to the left ventricle. So that's me, yeah, because they had to know all the veins. But you won't get that question because I don't do anatomy anymore. Okay, we saw this, which is your conduction. There's certain things that are important to know about what cardiac muscle, how cardiac muscle contracts in comparison to skeletal muscle, right? And I don't know if you remember, but when we did skeletal muscle contraction, and I'm gonna do the white board. Let's see. Okay, do you see that? Okay, so skeletal muscle contraction was, why do I do that line? Something like that, right? So you have the latent period right here. That will be the contraction, so action potential. And then you have a repolarization and coming back to relaxation, right? And the peak of this wave is it's kind of like high and steep and narrow. You remember that? Latent period, the cells are getting ready, depolarization, contraction, repolarization, relaxation, going back, right? We remember that, right? I hope. And if not, just make a note of it. So now, look what happens to cardiac. So you have a very, very tiny latent period here in A. Then you have the contraction goes high, right? Massive contraction, because the atria contract at the same time with all their mighty, because they have to push the blood down. And then the ventricles need to contract with all their mighty, right? But look what happens. It's not up and down. You have this little wave here, right? Stop emailing me. Okay, so see how the green line goes? It's not up and down like skeletal muscle. So why? Because the heart needs to stay contracted longer than what skeletal muscle fibers do. Because the heart needs to send all the blood to two different places at the same time. And also because it has this refractory period that is wider, this wave is wider, they get more calcium coming in to sustain that contraction. So the heart has sarcomeres, same with skeletal muscle. They also need calcium, same with skeletal muscle. They have it in the sarcoplasmic reticulum, but because of this type of contraction, they also need calcium from the outside, meaning from blood. So not only the calcium comes from the sarcoplasmic reticulum, they also get it from the outside in blood. So that's why calcium levels are so important, right? Not only we have to have them sequestered in the sarcoplasmic, but for heart, we also need to have certain levels in blood because they depend on that calcium as well to sustain the contraction a little longer. Skeletal muscle is like, whoop, whoop, contract, relax, right? Heart needs to contract, create tension, then I'm gonna relax. Get it? So it contracts the same way, but not really. Since it acts as a unit, it has to stay relaxed a little longer, and it needs to stay contracted a little longer. And the importance of that is because the heart needs to create enough tension. See if I have it here. Here's the tension. So the contraction is strong enough because the heart is creating enough tension. Just think that it's like a container with a liquid that is not going anywhere for a little bit, right? So it's creating tension on the walls of the heart. So we create that tension in the atria first, because then we can contract really fast and powerful. And then the blood starts to fill the ventricles, and the blood, as it comes into the ventricles, starts to create this pressure against the walls of the ventricles on the inside. This is what we call volumetric tension or pressure. It's pressure because of volume that is inside a container. This is physics, right? But that's how you have to treat the heart. Like it's a container that it gets all this blood inside and it starts to create the pressure, the tension in the fibers, so the fibers can contract as a unit. So the ventricles can contract as a unit, pushing all this blood out. Is that clear? Little different than skeletal. Skeletal goes up, contract, down, up, right? It doesn't stay that long, contracted or relaxed for that matter. Let me see. I think that's very, okay. Just a little bit on lymphatic, and I wanna do a little drawing before I go to chapter 14 and see if I can rush what I want you to know. If not, we can do it next week as well. The lymphatic system, if you notice, is at the end of this chapter, is another system. We have a total of 11 systems in our body, right? But the lymphatic is very related to the cardiovascular, because not only we have what they're called lymphatic organs that you see here, which ones are those? The thymus, the spleen, the lymph nodes, all those we call lymphatic organs, right? But we also have lymphatic vessels. And in our books, we color those yellow or sometimes green to differentiate from the red and the blue, right? Artery or vein. And these lymphatic vessels are everywhere. If you notice, they're everywhere in the body, right? You have it in the legs, in the groin, here in the abdominal, thoracic abdominal cavity, pelvic cavity. You have it up here, you have it under the arm, right? In around the breast region. But what the lymphatic vessels do is that they collect excessive extra fluid that it may collect in the tissues. So when we're doing the exchange of nutrients and oxygen, remember, oxygen and nutrients, they come in the blood. Now, blood doesn't come out to the tissues, but yes, we have diffusion of the oxygen and the nutrients. And because they're dissolved in the plasma, a little droplet goes with it, right? And may get stuck in between the tissues. Now, lymphatics are picking up that extra fluid and they're dumping it back into circulation. So imagine if we didn't have lymphatics, and in fact, there's a picture in your books for somebody that has a parasitic infection that blocks the lymphatic tissues, the patient will have tremendous edema, accumulation of extra or interstitial fluid, right? So the lymphatics, they run very close to our blood vessels because any fluid that comes out is going to be reabsorbed by the lymphatics. And what happens is that that little fluid that when it goes into the lymphatic vessels is called lymph, right? It's going to be filtered mostly in our lymph nodes. We need to filter that little fluid that came out of the blood vessel, right? It's not blood, it's just fluid, plasma-like, right? It needs to be filtered before we put it back into general circulation. Because if the lymph picked up a bacteria in the tissue and we send it to general circulation, then the next cycle of cardiac contraction, we can send bacteria and cause a septicemia, generalized infection in the blood, right? So these lymphoid organs and lymph nodes, they're filtering the lymph before it goes into general circulation. Now the lymph is drained into venous circulation. So ultimately, all the lymph comes into the subclavian veins, okay? And the subclavian vein drains into the superior vena cava, which goes into the right atrium. So we have these massive little lymphatic vessels that are constantly reabsorbing or picking up any extra excessive interstitial fluid that there may be in between the cells. And we don't want to leave that there, right? Somebody's asking a question. I can't see it, sorry. Where am I? Stop. So that does the heart redistribute the extra fluids for the lymphatic? No, not really. The heart doesn't do much. The heart, what happens with the lymphatic is that all the lymph that we pick up from the tissues, it goes into venous circulation. This is a way also of maintaining blood volume. Remember, why do we need to maintain blood volume? To have a good blood pressure. If we leave this extra interstitial fluid in between the tissues, not only we can create edema, which is painful, but we're also going to be affecting blood volume. All that fluid needs to go back to circulation, and that's what the lymphatic does. It will collect it, it will filter it, and it will send it to venous circulation so that the whole blood volume is kept. So I wanted to see if I can do this with my drawings, which are not that great. Okay. So we have, oh my God, that line. We have an artery. Forget this line. This is an artery. And the artery branches into smaller and smaller, what we call capillaries. And then in the middle, we have our tissues. And then we go with tiny, tiny veins, which are also capillaries. And they're all going to collect in a vein. So this is actually what a capillary bed looks like, right? So the lymphatics are kind of like intertwined all around here. So those are your lymphatics, right? So when we get my arteries bringing oxygen and nutrients, they're gonna send it to the cells, right? They are waiting for that oxygen and those nutrients. So when they do this diffusion to the tissues, that's when you lick little fluid droplets. And that's what is picked up by the lymphatic, so that we don't waste any fluid. We don't wanna have an issue with blood volume. Now on the other end, what are my veins picking up? My veins are picking up carbon dioxide and waste. Now, where is this going? This is going to the right atrium, which then goes to the right ventricle, which then goes to the lungs, right? We want to oxygenate this deoxygenated blood. And this one is coming from where? This oxygenated blood entered the left ventricle. It went to the, left atrium, went to the left ventricle, and then went to the aorta. And in the middle, right, we have all the different smaller arteries and veins. So lymphatics are taking care of any little leakage, right, that happens there. Either way, when we bring oxygen and nutrients, or when we pick up carbon dioxide and waste, because there's a diffusion, right, between the cells and the blood vessel. And we don't want to leave any tissue fluid in the tissues, because that would cause edema. And that is going to affect blood volume, which in turn affects blood pressure, right? So any questions on this? This makes sense, right? All right. Oh, that's not what I wanted. Sorry. Okay, you all see that? Yeah, okay, we don't have a lot of time, but I want, and we can go back to this, don't worry about it, but certain things that are very important. All right, so look at this. This is how we distribute our water in the body, right? So we have about 3 to 3.5 liters in our blood plasma volume. So how important is to maintain blood volume, right? And then we have a lot inside our cells, right? Look, 27 to 30, but those are inside our cells. They stay there. And then in between, you have this interstitial fluid. It's between the tissues and the blood vessels. And so this is the little fluid that needs to be reabsorbed back into blood. Now there's also some water distribution in your GI tract, and we're gonna see that when we study digestive system. But we don't want this interstitial fluid to be that high because that causes edema, right? So an edema causes pain, and edema causes low blood volume. So they're all related, right? So if anything from this chapter, this is the one that you should know. And I don't have enough time in 10 minutes to explain it, but I want you to study this picture. And we're going to talk about it next week. I know that next week is immune, but this is extremely important for you to understand. What you have here is pretty much my, let's see if I have it again. It's my drawing. That picture is pretty much this, all right? But obviously it's a little nicer. But if you learn anything on chapter 14 is this picture here. Because this picture explains everything, how we bring the blood from the arteriole, which is a small artery, and it becomes a capillary, right? And here we will have the cells, tissues, right? And then how little venules are gonna pick up carbon dioxide and waste with fluid, of course, and it's gonna be returned through venules to the major veins, superior, inferior vena cava. But there's a lot of little arrows here that are playing with different pressures because we're talking liquids here, right? Fluids. We have the pressure of the blood. We have the pressure that could be building up in the tissues if there's a lot of tissue fluid. We have the pressure that we have at the end of the venous end in the capillary bed, okay? So there's a lot of different pressures and little numbers here that unfortunately you have to know. That's why I said, if you have one thing to know from this chapter is this picture. But I wanna go over with enough time so you understand. But you have tissue fluid here. You have all these little arrows. The arrows mean diffusion, going one way or the other. So when you look at the little arrows, means diffusion. So if you notice on this end, which we call the arterial end, you see arrows going up, right? What is that? We're bringing oxygen and nutrients to my tissues. That's why the arrows are going from the capillary arterial end to the tissues, right? And what happens at the other end? Look at the arrows, where are they going? The major ones, they're going back into the veins, right? Why? I'm picking up carbon dioxide and waste and any other fluid, right? So at this end, which we call the venous end in the capillary bed, we can reabsorb up to 85% of all the fluid. So the veins are pretty good, right? But what happens to the other 15% that is here in the tissues? That's what the lymphatics will pick up. Is that clear? So the lymphatics that are gonna be here, very close, they're gonna pick up that 15% that the veins cannot pick up. And that's when everything works really nice, right? Because that's when we keep our blood volume, and this is when we have health. We know that cardiac patients suffer, and cardiac patients suffer from edema and proteinuria. One of the things that we saw in one of your discussion boards. So before we go, when we have the right blood pressure, we have enough force on this arterial end to push things that our tissues need, right? So that's having the right blood pressure. When you have the right amount of blood pressure, you have enough force still left in the venous end to pick up whatever you need to pick up in that end. But think about if you have high blood pressure, yeah? The force by which this blood is coming in with is gonna push things out that may not need to be out because it's so forceful, high blood pressure, pushing, think about a sieve, right? Pushing through the endothelium, that's when edema comes about because you're pushing a lot of stuff that should not be pushed out into the tissues. Yeah, that's high blood pressure, not good. That's why cardiac patients, a lot of them suffer from edema. See the connection here, right? You're pushing a lot of things out into the tissues because the force, the pressure is too high. But if you think about the other end, what about a person that has very low blood pressure? Well, my poor little tissues may not get everything they need. There's not enough force to push these things out to the tissues that they need. Interesting, huh? All right. So for next time, please study this little picture and then you can ask all the questions you want, but I want to go over what all these different pressures are, okay? So that you really get the big picture. What is oncotic blood pressure, right? Which is very important. And we're going to go back to that in urinary system, okay? Boy, we did it. We almost did 2 chapters in one day and labs. Wow. I'm proud of myself.
Hey, Professor, I had a quick question.
Yes.
So for chapter 13, what we talked about today, is that all we need to know? Or is like
No,
the
you
others-
need to know everything that is on the narrated PowerPoint.
Okay.
Yeah. That's why they're narrated, so you can listen to all of it. When I meet with you, I don't have time to go over again, but I just did the major points, right? Any other questions? No? Well, if you have any questions, I'll be here for the office hours on Thursday. And then I hope to see you in my presentation. Well, I don't know if I'll see you, but I hope to see you in my presentation in Thursday at 4. Okay, but I'll be in office hours at 2 on Thursday. Yes? So if you have any questions on what we did today, then you can ask me there too. That's it. All right, you guys. I'll see some of you on Thursday.
Thank you.
Thank you.
Bye, everyone.